My name is Derek Steele. I am the Interim Executive Director of the Social Justice Learning Institute, here to facilitate today's conversation. But to be honest, I'm gonna be standing out of the way most of the way because I know there's a lot of information to be able to provide to you all in this hour, and we wanna have that conversation with you. So most of it will be centered around our amazing guests that will have an opportunity to introduce themselves in a second, and also questions that come from you so that you all are having a dialogue and we're just facilitating the space, all right? So we're excited to be here. Let's talk COVID. I don't want to give away the movie before it starts. I'm going to introduce you to our amazing set of, well, you know what? Like I said, I don't want to give it away. I will just say, Dr. Garner and Dr. Briggs, please bring to the floor yourself, explain who you are, and where the body of work in which you come from and where you're starting this conversation with our family.
Excellent, Derek. You know, I want to thank you. I want to thank the Social Justice Learning Institute for putting this together. You know, this series of conversations is critical, right? COVID-19 has impacted our community, and we really need to come together to come out of it. And so, as an introduction, my name is Dr. Omai Garner. I am the co-founder and board chair of the Social Justice Learning Institute. And so I've worked closely alongside with this organization and been a part of this organization for the last 13 years. So proud of the work that we've done, so proud of the work that we're going to continue to do. I am also an associate professor in clinical microbiology in the Department of Pathology and Lab Medicine at UCLA. And for my clinical service, I run an infectious disease diagnostic laboratory. So as related to COVID, my laboratory with UCLA Health has done over 250,000 COVID tests to be able to support patient testing at UCLA. And I bring the perspective of, you know, really the ground floor of COVID-19. I'm a virologist. You know, I think a lot about the vaccine, a lot about testing, and I'm on the ground as far as working with the virus and being able to help diagnose patients. So that's really the perspective that I bring. And I want to toss it over to Dr. Briggs, who I am honored is joining us today.
Oh, thank you so much, Dr. Garner. And first I have to say again, thank you, Social Justice Learning Institute, for the invitation to actually be here with you all today. It's my pleasure and my honor, and looking forward to a great and interactive conversation. One thing about me, I am actually an emergency physician. So I have been on the front line at UCLA Health since the pandemic started, directly seeing patients and treating patients with COVID, and really trying to make sure that we're not only taking care and protecting our patients and our communities, but also all of our doctors and nurses and other healthcare professionals that are right there in the clinical setting. So outside of my clinical work, I am also the Chief of Health Equity, Diversity, and Inclusion for the UCLA Hospital and Clinic System. And so that work actually focuses on how do we ensure that we are addressing health inequities and doing what we need to do, not only as an institution, but partnering with community and other community-based organizations in order to address all the factors that lead to health inequities. And as Dr. Garner mentioned, COVID has hit especially our Black community and our Latinx community and our Indigenous communities significantly. And so it's really important that we have these discussions and really talk about vaccine acceptance and all of the different factors that go into there so we can definitely emerge out of this pandemic. So pleasure to be with you all today.
All right. Those are both amazing introductions. And I think we'll just, I want to frame the set of conversations that we were going to be having really briefly, if you don't mind. Today's discussion, if you saw the invite, is COVID-19. Let's talk COVID, particularly around the Black community, right? And I just want to let it be known that in these series of conversations, we're thinking about those of us in our communities who have been most impacted. And so we want to have these nuanced conversations that have questions that are particular to our different parts of the community, right? So today, yes, we're starting with the Black community, and well, you know, when you're talking about the Black community, you're also talking about other spaces of communities of color. So there's the different nuances that may come into play along the way. But we'll be talking about our Latinx sisters and brothers, as well as some of our immigrant families and what the expectations and what it's looked like from those standpoints. So I want to make sure that you are all feeling welcome about coming to these conversations as we continue to go down this road. Dr. Garner is excited to help bring his peers to the table to have these discussions so that there's not just representation, but also an understanding from the walks of life that most of our community members are going to be coming from. So with all that being said, let's jump into it, right? We want to talk COVID, but before we can even get there, knowing the things we know about the beliefs and the history of the medical industry and the healthcare industry with the Black community, I want to kind of ground this conversation and get your thoughts about the origins of where some of this mistrust may actually lie from the Black community. And maybe not even just mistrust, but just taking that hesitation before you step into the realm of things that come to bear when it comes to the medical industry, as well as healthcare in general, and how it's actually shown up in our lives.
Yeah, I'm happy to start off with that. And I think all of the concerns about distrust towards the medical community and the public health community, and really having significant concerns about everything that's going on today, is completely valid in every single way. Our country has a long history of complete unethical experimentation on the Black community and other communities of color. And it actually started right with the Atlantic slave trade in 1619. And in fact, part of slavery was to intentionally withhold medical care and intentionally keep the slaves in lower health in order as a sign of our ability to oppress them and to keep them in their places. And so there's even something called the slave health deficit, which extends all the way back to 1619, which explains a lot of the chronic diseases that Black community still has to this day. And now we all know many different things about some of the experimentation that was done within the Black community. Some of the most well-known ones, of course, was the Tuskegee study, which specifically withheld medical treatment from poor Black sharecroppers from the years of 1932 to the years of 1972, even when there was a cure. And so a lot of us have been really making sure to explain that, yes, there was a lot of unethical experimentation that was done on the Black community, but it's not all historic. We still have racism within our medical community now, which many of us are daily trying to counteract that and really make sure that we are correcting the healthcare industry. But although we have historic experimentation, and although we still do have some challenges, one thing that we do today have is that there's a lot more of the Dr. Garners and the Dr. Briggs and many others who are not just Black physicians and Black scientists. We have a lot of people now that are 100% committed to ensuring the appropriate health and health care of all of our communities, and especially our Black communities. For the first time, we are in various different positions where we can actually help to study, for instance, COVID-19 and create the various different vaccines and make sure that they're done appropriately and safely, and be able to partner with our communities of saying, listen, we have been at the table now, which we weren't at the table decades and decades ago. And so there has been a significant change in terms of where we are as a healthcare industry, where we are in terms of public health, and which a lot of those transgressions that occurred in the past are not only are they outlawed, but we're actively making sure that bias and racism and other forms of discrimination do not enter into what we're doing in terms of supporting our communities. So that's what I would say. The medical mistrust, it's valid because we have a history of that in the country, but now we're at a new stage where it's important for us to realize we're now all at the table in order to ensure the care is appropriate for our communities.
That's fantastic. Dr. Garner, would you like to add?
No, I mean, there's a reason why I chose Dr. Briggs to join us today. And you can see very clearly with that answer, you know, I completely agree with what it is that she has said. I am hopeful that we are going to be able to continue to make progress in medical mistrust, but you can see the history was from the very beginnings of Black people being brought here. And so that is what you're up against. And when you're up against something that is 400 years in the making, you know, even if you're making large steps, the mountain you have to climb is so high. And so, you know, it's really community sessions like this, discussions like this, and to Dr. Briggs' point, more and more Black physicians, more and more Black scientists are becoming a voice, a national voice, to bring these things to attention, to have these conversations, not in this group, not in community groups. Look, this group has been having this conversation for a long time, but also in the groups that are in power that are keeping those things in place. These conversations are starting to happen. So, no, I completely agree.
That's fantastic. You know, just to kind of drill down in, again, because this is a ground setting piece of it, right, of the discussion. So I'm super thankful to be able to have more folks like you who are speaking up in your spaces, and also, you know, check in folks that may be, you know, not doing the things that could be critical to build trust, right? So I'm just curious, like, how is that shown up in your atmosphere and in your space, and like, what kind of course correction have you helped to do in your career since you've been in the space as well?
So, as I mentioned, my non-clinical job, when I'm not in the ER taking care of patients, my job is to oversee the behaviors of doctors and nurses and other healthcare professionals as they're delivering care. And not only within, for instance, UCLA, but also start to build some of those frameworks for even across the country. And one of the first things that we're doing is that we're calling out racism. We're calling out bias. We're saying, guess what? There's different forms of racism. We tend to think about interpersonal racism. For instance, if one person shares feelings of racism towards another and expresses that, but we have what's called institutional racism, where there's certain things that's built within all of our different structures in our society that continue to perpetuate racism and continue to have one groups that are actually more advantaged than others in terms of health or in terms of other opportunities. And so one of the first things that we're doing is, number one, bringing that awareness to the forefront so that we, even as docs who are providing care to patients, are saying, oh gosh, didn't even realize that that's actually causing harm if I say that, or if I do that, or if I don't take into account this or that, or I didn't think about the fact that they may have had this other kind of experience. But then what we're also doing is that we're starting to build a new framework. So for instance, thinking about what I like to call the equity check, where everybody's going to have to pause and say, okay, did I provide the same level of care to that person as if I would provide to somebody who has the same identity or experience as I do? And if the answer is no, like you provided different care, then that's a problem. We need to go back to the drawing table. So there are a lot of, number one, awareness. There are new policies and procedures, but then also making sure to teach all of our healthcare professionals to really start checking themselves in the care that they're delivering to ensure there's no elements of racism or other forms of bias that's within their care.
That's the equity check. I love that. Like as an equity first organization, that resonates very well with me, and I'm sure some of my peers who may be on the line as well. Dr. Garner, did you want to kind of talk a little about what it's looked like from your perch in the space that you're in with New Orleans?
Yeah, absolutely. You know, I think as Dr. Briggs can attest, and especially as being a Black scientist, there are just not a lot of us. And so when you look in physician spaces, when you look in scientist spaces, and that is not for a lack of young students being interested in science. That is just not true. Young Black and Brown students are very interested in science. It's just the system is set up to stop them from success. And so, you know, really a lot of what I like to do is attempt to build pipeline, right? Attempt to be able to mentor so that we can create more Black faces in these spaces and have that influx of people of color help to lead the change that Dr. Briggs is talking about. Because then in those spaces, it starts to normalize that conversation. It starts to normalize those people being there. So it's not to suggest that this whole thing is a numbers game, and yet numbers are a very important part of it. So for me, the way it really manifests is that I take a personal responsibility, having made it to this point as a Black scientist, to bring as many people up with me as I possibly can, and do that not just on an individual level. Look, I love individual mentoring. I do it as much as I possibly can, but also build structure in place so that lots and lots of people can come through, lots and lots of people can have opportunity. So that really, Derek, is what it looks like for me.
That's fantastic. So we're talking about transforming systems from within, right? And then also building pipelines so that others can actually come and be a part of the movement. I think that's fantastic. I want to get a chance to get the Q&A because I want to provide space for the community conversation. So I'm going to pull together two questions that I had. So in the last 16 months, and I say 16 months because it's like December 19, November, December 19, all the way to today. Like, what was the moment in time that you realized the seriousness behind COVID-19? And then, you know, in that answer, kind of begin to start talking about some of the solutions and a push behind some of those solutions to be able to bring down the impacts that we began to actually see. And I think this is an important question, mainly because with you, Dr. Briggs, being in the ER, I think that personal experience looks at it from one angle, but then from your perch, Dr. Garner, and the changes of how we're bringing solutions to the table, I'd love to hear you kind of let us know, like, what does the world look like from those lenses?
You know, I think for me, especially as an emergency doctor, but also as someone who is focused on public health, I probably recognized the seriousness of this in April of 2020, when I was in the ER, and that's when we had already all shut down the whole city. And every patient that was coming in was incredibly sick with COVID, to the point that they were coming in gasping for breath. They were coming in literally almost on the verge of dying, in which it was patient after patient after patient. We were trying to hurry and get to them and try to, you know, put down breathing tubes and try to save their lives. But what was scary about it too was because, unlike anything we've ever seen, we're normally used to like dealing with heart attacks and car crashes and gunshot wounds and whatever it is. And we just run on in and we try to save people's lives. But this was the time that we had to take a step back, although we saw people that were literally trying to breathe for their life. And we had to protect ourselves, but also protect each other. And that's when I realized how serious this virus was and how serious the situation was that we were in. And then starting to look at the stats, like from a public health standpoint, and how our Black and Brown communities had the highest rates of COVID infections, the highest rates of hospitalizations, and the rates of death were starting to go like this, completely upwards. And that's when my heart broke, and I was like, this is serious. This is unlike anything we have ever seen in over 100 years. It's not the flu. It's not any other type of virus that we've seen. This is one of the most deadly things that we have seen in almost 100 years. And that's when it really clicked for me.
Yeah, just to follow up on that, you know, I run a laboratory that does all of the testing. And so I see and review every individual positive test that comes through my laboratory. And when we started in March and April, we were one of the only laboratories in the entirety of Southern California that actually had a test. Now, lots of reasons around that, lots of problems that were in that place, but we put a test together, but our test was just for UCLA patients, UCLA health patients. And what happened over March, April, and May is I just kept watching the numbers of positives climb, the daily numbers of positives climb. And what I found so disturbing wasn't that those numbers were climbing at UCLA, it was that nobody else was doing testing. And so what it meant was that you had this invisible disease that was spreading its way around. So many people were getting sick, but in hospitals that didn't have the resources, in hospitals that didn't have the laboratories that were able to put together testing like we were at UCLA, they weren't able to provide the support that we were trying to provide for our physicians in our ER. And so being able to correctly protect yourself, diagnose and treat this illness requires knowing who has COVID-19 and who doesn't have COVID-19. And so it just became very aware. I mean, I became very aware right away of, we all are understanding of the disparities in healthcare, right? It's not an equitable system. The things that are available at UCLA Health are not available at MLK. But I didn't think of those in the context of lab testing. I didn't think of those in the context of infectious disease until this pandemic. And then suddenly it just became very clear, because I would talk to my colleagues at MLK, you couldn't get a test if you lived in that neighborhood, right? You were on the west side of Los Angeles, you can come to UCLA, you can get a test. You're in South or East LA, you don't have an option for getting tested. So then how do you know to go to the hospital? How do you know to protect your family? And so really that was a distinct wake-up moment for me about the disparities of this particular disease that doesn't create disparities itself, but just exacerbates the disparities that already exist. And it just became very, very clear from a testing perspective. And we've seen that throughout the pandemic. There are still places in Los Angeles County where it is exceptionally difficult to get tested for COVID-19. Just very, very, and that's not even talking about the rest of the country. And those places almost all the time overlay on communities of color.
Oh man. So with the way that you all frame this, right, the next step that actually came into play was immediately everybody talking about the vaccine and how this was going to happen. And I can tell you, I'll be honest, in my spheres, in my circles, you know, my group chat with my friends, to talking to my family members, as the quickness of how this was all coming to bear alarmed everybody. It was like, wait a minute, man, I've seen this story before. I've seen how this plays out, right? So I would love if you could like to go a little deep into how the vaccine actually works, right? Because I know we have the mRNA versus Johnson & Johnson's, which went down the road of historically how vaccines are usually made, right? I would love for you to kind of talk about the difference between the two, but really kind of giving us the breakdown and as simplest terms as you can of how this actually works and why this is a good thing from your point of view, if you feel like it is a good thing from your point of view.
Yeah, absolutely. So I'll just start with 100%. It's a good thing from my point of view. So I don't want
to
thumbs up
at all.
Unequivocally understand.
And I think bringing it down into pieces is good. So, you know, what I'll talk about is how do vaccines work? What is an mRNA vaccine? How it produces protection? And then, you know, I'll toss it over to Dr. Briggs to talk about, you know, how did they prove it was effective? Is it safe? You know, kind of all the downstream questions from that I think we're definitely going to spend a lot of time talking about. So when you get sick with an infectious disease, let's say with a virus, after you're sick, your body produces something called protective immunity. This protective immunity is held in something called antibodies that circulate in your blood. And what this protective immunity does is it stops you from getting sick from that same thing a second time. So the way this works is you now have these antibodies, right? You got sick with that virus, you now have these antibodies. So if you encounter that virus again, your immune system is so primed to fight it. These antibodies fight that disease off before you ever get sick. So protective immunity is wonderful. The challenge of protective immunity is you have to get sick the first time to create that. So as we all know with COVID-19, over 500,000 people have unfortunately died in the United States with their first infection with COVID-19. They didn't get a chance to build protective immunity. The other challenge with COVID-19 is that people are experiencing very, very long-term, very, very debilitating symptoms from COVID-19, right? And so again, even though those people then die, they're still having the negative effects of having the virus. So a vaccine really asks this question: how do you build protective immunity but not expose someone to the full disease? And that's the trick, because if you can do that, if you can get those antibodies set up, then what happens is the first time you encounter that virus, if you have that protective immunity, you fight it off and you don't get sick. And so that's really the goal of a vaccine. Now, there are a lot of different ways that you can actually create a vaccine. One way is to take the virus itself and then kind of beat it up a little bit and give it to a person so it doesn't cause the full disease. This is how the measles vaccine works. And another way to create a vaccine is you can actually take a small piece of the virus, right? You need a lot of medical research to determine which piece is the right piece, but you can take a small piece of that virus, give that piece to a person. They're going to make an immune response, right? Create that protective immunity, those antibodies to that piece, and that will allow them to fight off if they ever see the full virus. And this is actually the concepts of how we build the vaccine for COVID-19. And so everyone in here may have heard of the spike protein, right? They talk about the spike protein a lot. The spike protein is a small piece of the virus. It's on the outside of the virus. What it allows that virus to do, it actually allows that virus to infect the cells. But if you give the spike protein itself to a person, right, in an injection, the immune system creates antibodies and it stops that protein from allowing that virus to infect a cell. So medical research showed us that if you use the spike protein as the vaccine component, you can create immunity, you can create protective immunity. So there are some vaccines, right? They're protein vaccines. They just give the spike protein. Now, what's interesting about our vaccines is that our vaccines, both mRNA vaccines and the Johnson & Johnson, which is an adenoviral vector vaccine, teach cells how to make the spike protein. So let's take a quick step back and talk about the virus. So COVID-19, the virus, is composed of really two parts. The outside part where the spike protein is, and then inside the virus, it has a genome, right? It has genetic instructions to make the virus, just like our DNA is genetic instructions to make human beings, to make human cells. That genetic instruction is called RNA. And so an mRNA vaccine actually uses just 10% of the RNA from COVID-19, just that RNA that makes the spike protein. You can inject that RNA into the arm. What happens is the cell will take it up, make spike protein, present that spike protein to the immune system, and then create protective immunity. The J&J vaccine works in a very similar way. So you've made the immunity, but you don't have to get exposed to the disease. It was very effective, and we'll talk about its effectiveness and its safety, but I want to talk a little bit about what's in the vaccines, because this is a concern, right? A lot of concern about, all right, well, you've got mRNA in there, but what else is in there? Because in a lot of the media, you'll hear about things being in vaccines that are potentially dangerous to people. So when they made the Moderna and Pfizer vaccine, which are both mRNA vaccine, they kept the components low, meaning there isn't very much inside. Kind of if you flip the box over, you look at the ingredients that are in that mRNA vaccine, it really only has 4 ingredients. The mRNA itself, which is going to make the spike protein and teach the body how to make the antibody response. A lipid layer around it. You can almost think about this as like a layer of fat or a layer of butter that surrounds the outside of the mRNA that actually encourages the cells to take it up. Salt and sugar. These are the only components in the mRNA vaccine. And so it's important to be able to keep the formula simple but effective, so that it allows the immune system to create the response it needs to create. The final thing that I'll say to Derek's point is, why did this happen so fast? Right, this question came up, right? This disease just came about in December or January, and we're now a year later, you already have a vaccine. So one reason this moved so quickly is because medical science has been working on an mRNA vaccine for the last 10 to 15 years. This is not new technology. It's new to be approved, but it is not new in its workings. And when there was the original SARS, so if everybody remember back to 2003, there was the SARS outbreak, they made an mRNA vaccine for that particular organism. The challenge, what happened, and what's not a challenge, the good thing is that disease went away. So if a disease goes away, you don't distribute a vaccine for it. COVID didn't go anywhere. And so as they were making the vaccine, ended up COVID was getting worse and worse and worse. So it created this scenario where they were able to use the science to make a safe and effective vaccine product and distribute it. I will now toss it over to Dr. Briggs to talk about, how we know that it works and the phase 3 trial studies. And then of course, the question on everybody's mind is this thing going to be safe?
And so thank you, Dr. Garner. And as you can see, he's an expert in all of these things. And I want to underscore that the vaccines, they're not new. It's just, again, there was so much focus, so much just we have to get out a vaccine, that's how the things were able to progress. And so one thing that people have said is that, oh my goodness, and especially with the term Operation Warp Speed, which I'm so happy we're not hearing about that anymore, but that led to a lot of concerns, and especially throughout the country, in the Black community, all over social media. But in all actuality, these vaccines went through the same exact safety checks as any other medication, as any other antibiotic, as any other vaccine that we've had. So there were no corners that were cut, but the difference is that the processes, normally the steps are step A, then step B, then step C, then step D. Essentially what happened, everything was streamlined. So all of the unnecessary steps that normally went in, like the administrative work, or let's finish this before we even think about packaging, everything was done more efficiently because of course we're in a pandemic. And so one of the things that they did, especially in all the clinical trials to test each one of these different vaccines, is that people of all backgrounds, including Black people, brown people, others, were all part of the clinical trials. And what they actually did was take these vaccines and watch to check for the safety. And what was found was that for both of our mRNA vaccines, they were incredibly safe, as well as highly effective, meaning 95% or more effective, which meant if you got vaccinated and then you got the virus, you would not die. You would not have severe illness that would actually cause you to go to the hospital. And most people were able to fight off the virus in every way. The Johnson & Johnson vaccine, although it's one shot, it's the same thing. It's been shown to be very safe and highly effective in multiple different backgrounds of people, all the way up to about 80 or so % that we've seen here in the US. So there were extensive trials. They looked at this, they found that it was safe, found that it was highly effective, and that's where we are today. Now, I was one of the very first people to be vaccinated at UCLA Health. The reason why I stepped up to do that is because I looked at the science. I made sure to think about all the different things that I would want to know in order to ensure that I'm safe, that my family's safe, and my patients were safe, and it all checked out, including the National Medical Association, which is the oldest and largest association of Black physicians, or have completely endorsed the vaccine. And in fact, the president of Meharry Medical School, who is of course a Black man, was part of the group to evaluate the safety of this vaccine. So as I mentioned before, all of us now are at the table looking at all of these processes to make sure that these vaccines were developed appropriately and that they're safe. So even today, I'm vaccinated. My entire family's vaccinated. I got a whole bunch of friends that are vaccinated. I'm still trying to get my husband vaccinated. So every day I'm looking like, we got to get your vaccine. But literally people in the space, I would never recommend something that I myself would not take, or I would not recommend for my grandparents, for my parents, and for my patients to take. Now, some of the quick things too about side effects. People, you may have heard about, well, gosh, don't you get side effects? The most common side effects that normally you'll get, especially after the first or second shot, is a little bit of arm soreness, which is standard of what normally happens even after other shots, such as the flu shot. However, you can also go on to get things like mild headaches, may also feel like body aches, which we call myalgias, and then some people may even run a very low-grade fever. But the good thing is that all of these different side effects are just showing that your body's responding to making those strong antibodies the way that Dr. Garner mentioned. And most of the time, all these symptoms go away within about 24 to 48 hours. I myself, especially after my second shot, had a headache, had some body aches, but then they all went away. But I can tell you, I much rather have some body aches or a headache that lasts for 24 hours than to get the COVID-19 virus, end up in the hospital and potentially die, or even if I don't end up dying or really severe in the hospital, potentially having long-term effects of COVID-19, which we've been seeing so many cases of, where people have problems thinking, people have problems breathing, and people can even start to have problems with their hearts. So overall, vaccine, no corners were cut. It was just more of an efficient process. It went through all the same exact testing, the way any of our medications or vaccines are made. And it's been proven to be safe and highly effective in various different patient populations.
All right. Okay. I'm sold. I'm all in on everything that you are sharing, and I really appreciate the way that you're really kind of framing and taking it apart so that people can really understand the intricacies of each of the different sections of this. And so I'll be honest, I folks who are on this have probably heard a lot of this information and kind of understand it. And so what I want to do is get into some of the more nuanced questions that are being asked in the chat, and also provide folks an opportunity to engage with us directly. And we could have did this as a webinar, but again, this is like a family conversation. We want to make sure that folks have the access and there's not that barrier to be able to ask the questions. So I did ask already for these folks who asked in the chat if they wanted me to ask for them or if they wanted to ask themselves. And so Kimberly Upchurch, she asked a couple of different questions, but I'm gonna put it together. The first of it is, if you already had COVID, what is the time span that you should wait until you get the vaccine? And then how long does the vaccine actually protect you, right? Do you have to get it annually, or, how does that work?
Yeah, I can speak to whether or not we're going to need a new vaccine or a new booster, because I think it's a question that's on everybody's mind, Kimberly, because, is this a yearly shot like the flu? Is this something that's going to go away over time? So we need to be able to get another booster, and we don't know when that's going to happen. And so I think the answer right now to that is we're not exactly sure, but I'm pretty hopeful. So let me frame that in a context. There's really two ways that you need a new vaccine. One, that protective immunity just wanes over time. So eventually those antibodies just aren't there anymore, and you got to get a booster shot to be able to do that again. This is common with the disease called whooping cough. So anybody who's on here either has little babies or has family members with little babies, you get a pertussis vaccine. It's in that tetanus, diphtheria, pertussis series. And as you know, if you're about to have a baby, you're about to be around a baby, they actually give you a booster. The reason why they do that is because those antibodies for that particular disease, for whooping cough, for protection, only seem to last 3 to 5 years. And after that 3 to 5 years, you need to get another response to your immune system to make that protective immunity. So the question is, will antibodies just wane over time with COVID-19 vaccine? We don't know. That's something we actually have to continue to test. But remember, there are people who are in the clinical trials who got vaccines before any of the rest of us did. And those people actually give blood to be tested over time to see what their antibody levels are. Because if their antibody levels are high, all of us are good. But if their antibody levels start to go down, that predicts that potentially all of us that had the vaccine after them, our antibody levels may go down at that time too. Now, there hasn't been a vaccine where antibodies have waned after like a year. That doesn't happen. And so in that setting, we're pretty confident that people are going to maintain a high amount of that protective immunity. So that's one side. The other side is why we need a flu vaccine every year. So the reason you need a flu vaccine every year is that the flu mutates. It changes and makes new variants. And these variants, when they come around the next year, they're not protected with that protective immunity. Those antibodies can't even bind to them. You can even think of it as a brand new flu. So the question is this going to happen with COVID-19? And this is why you're hearing all about the variants and the different strains that there are, and do the vaccines work or they don't work? And that really is the question. Will there be enough change to the virus that we need a new vaccine product? Now, the virus can't change unless people are getting infected. So the reason why it's so important that so many people get vaccinated now is that if we can bring down the overall level of infection, it means there's a much less likelihood that a new mutation will show up and will be resistant to the protection caused by the vaccines. So it's a good question. We don't know, but it's something we're continuing to look at. And I will toss it over to Dr. Briggs to talk about how long after having COVID should you get the vaccine.
Yeah, and so the quick and short answer to that, Kimberly, is that we normally say as soon as your doctor thinks that it's safe, but normally between 30 days to about 90 days after your infections actually clears up. The thing about getting the COVID-19 virus is that your body's going to already start producing antibodies against the virus. That's that natural immunity that you build up. But what we recommend is normally anywhere from 30 days to about 90 days after your infectious symptoms clear up.
All right, that's fantastic. Hopefully, Kimberly, that answered exactly the way that you needed it and to be able to inform you about what next steps to take. I want to move on to Diana Hawkins, who asked a few questions in the chat because she wants to know, like, listen, since we having this family discussion, like I got family questions, right? So I'm gonna ask a few of them. The first one, she was kind of, there's the idea that the vaccine is not a cure, right? And so the question is, can you still get COVID even after you have already gotten the vaccine?
So I touched on this just a little bit in terms of the point of the vaccines is to prevent death and serious illness. And there have been a small number of cases that we have seen that after getting the vaccines, then yes, people may still have gotten the COVID infection. But once again, the difference is they did not progress to having severe illness, meaning they have to come into the ER to see me, and I may have to put down a breathing tube in order to keep them alive, and they ended up in the hospital and almost dying. No one has experienced that. So the point of the vaccine is, number one, to prevent you from getting any clinical illness from the virus, or at least preventing you from having any serious disease from the virus. So that's why. And so that's why this vaccine is so important, because we're trying to save lives. And oftentimes, I think COVID has impacted every single person one way or the other. And I think all of us have known people that have had COVID. But the thing is, sometimes you may not see the amount of people that are actually dying from it, or the number of people that end up really serious conditions in the hospital. And that's what we're trying to prevent, because those numbers are incredibly large and much higher than just about any other virus we've seen in a very, very long time.
Yeah, I will, just to add to that, because now we've had millions and millions of people vaccinated. What we're finding, and this is data you collect over time, is that not only is it exceptionally rare for somebody to have even moderate illness once they've had the vaccine to COVID-19, we're actually finding it's very rare for people to even asymptomatically have the virus. So more and more good news is coming out that not only do these shots protect against severe illness, which, as Dr. Briggs mentioned, is the entire point of a vaccine, is to protect against severe illness. They're even doing better than that. They're even stopping people from having any virus at all if they encounter COVID-19. So very, very successful. And we're getting stronger and stronger data by the month to suggest how effective these vaccines are at stopping COVID-19.
Oh, that's fantastic. So I want to ask the secondary question. I'm going to put two questions together, one from Diana Hawkins, but then also from Leilani DeGru. It's, nowadays, because of COVID, every time somebody cough or every time they sneeze, everybody looking at you side eye like, yo, what's going on, right? So, the question, the first question is, with things opening back up, and now students now talking about going back to school, and regular illnesses and the regular common cold coming back into play because we're now back in space with each other. How do you know the difference? And should you just be going to your doctor every single time? How does that go together? And then the secondary question underneath that is long-term effects. Like what are we seeing as far as that's concerned from those who got the vaccination as part of the trial? Like, are we seeing any of those types of things come to play out as well?
Right. So I'm going to go with the first, and then I'm going to pass the ball on over to Dr. Garner for the second for the long-term effects. So now that we're all starting to open back up and there's a lot more mixing and mingling, the truth of the matter is that COVID presents in many different ways. We see it most often, though, with fevers, with coughing, sometimes other mild symptoms. And the truth is, we oftentimes can't tell the difference until we test you. So until we get our vaccination rates much higher, and until we also continue to get what this is, this herd immunity, what I recommend is that if you are persistently, continuously having symptoms such as a fever or a cough or any other type of really severe body aches or anything else, go and see your doctor. We have widespread testing right now, and it's much better for you to be tested so that we can make sure to see if you have COVID or not. Because if you have COVID, we want to make sure that you're well taken care of, but also making sure that it does not spread to other people that may not be vaccinated yet. So there's now testing that is more widespread now in many different locations. So definitely get tested, because we want to take care of you. We want to make sure our families and our communities are still taken care of also.
Yeah,
Fantastic. Thank you. Go ahead, Dr. Garner, you got it.
I was just going to briefly touch on long-term effects. And so if you look at the vaccines themselves, the vaccines are not live viral vaccines. And so in that setting, the expectation then is beyond the side effects that Dr. Briggs had talked about, pain, light fever. We don't expect other side effects to be there, but we still have to study it. And this is what is key about this entire process, is that even though there is an expectation, when you get your vaccine, you can sign up to be able to, on your phone, report symptoms. And then those reports are thoroughly investigated, right? The idea here is that we have to look at this as a public health community. And so as we're looking at it as a public health community, that's one way we figured out that people who catch COVID can have very, very long-term symptoms. And so now the question is around the vaccine. And what we found, and remember, we now have people that got vaccinated, oh wow, over 8 months ago, right? There have not been long-term symptoms in that group. And people who have had symptoms, it's been within 24 to 48 hours of either the first or second shot, and they have gone away completely. What's also interesting, and I just read this study, Dr. Briggs, is that some of the people who have the long hauler symptoms from COVID-19 got vaccinated, and it helped to resolve those symptoms. And
That's
so
awesome.
not only, right? And so again, this is a complicated interaction between what's going on in these long haulers, but it appears that vaccination is assisting with that as well. And so again, while we don't expect there to be long-term effects from the vaccine, we will continue to study it.
And you know what, Dr. Garner, if I can add another piece to this too, that we've talked about with other groups. A lot of people are like, oh, wow, especially the mRNA, does it change your DNA? And does it give you mutations? Is it going to lead to cancer? Is it going to do things like rev up some type of autoimmune disease? But as Dr. Garner will probably provide a little bit more details about it, the mRNA, when it comes into your cells, it does not touch your DNA at all. It does not mutate your DNA at all. It stays completely outside of where our cells house that important DNA. In addition, the way that it triggers your immune system is in a very well-studied way of how we've been tracking the immune system for decades. So Dr. Garner is a virologist, but I also study microbiology and immunology during college. And the way that the body responds, this is all rooted in biology. So it's not anything new. We're not tricking the immune system to do something that it doesn't normally do. And so therefore, going back to what Dr. Garner mentioned, the likelihood of any long-term effects are highly unlikely based off of how the vaccines trigger the immune system, how they actually get your body to build the antibodies, which directly aligns with how our bodies already work.
Oh, that is fire. Thank you so much for going there, because there's another question that was already in that direction. And as Brianna said in the chat, she wants to thank you for the heads up on how it doesn't touch the DNA and being able to provide the information there. We started 5 minutes later, so I want to add a little bit more time on the back end of this, if that's okay with you all. Just kind of get everybody in the room. I want to pivot to Miss Nisha Joseph. Nisha Joseph wanted to ask her question live. So can you please unmute yourself so that you can go ahead and ask Dr. Briggs and Dr. Garner what you'd like to find out?
Yeah, sure. So hello, everyone. First and foremost, Dr. Garner and Dr. Briggs. I just wanted to know, how come, my question was, how come, for the COVID vaccine, individuals are being provided, or we're given rewards, for instance, like the Krispy Kreme donuts. I feel like that's a concern. Yeah.
Yeah, that's a really good observation and point that you bring up, Nisha. And I think what it really is that the way that we're going to get out of this pandemic is if we're all in this together. Because we won't get out of the pandemic if it's only 10% of us or 20% of us or 30% of us. And I think we all want to go back to a level of normalcy where our children can be in school. We can actually go and see our friends and our families and still take part in backyard barbecues and hug each other. And so I think we as a community and society are just trying to get back to our new state of normalcy. And I think there are times, like for instance, for the Krispy Kreme donuts, they're trying to say, hey, vaccines are a good thing. If you get a vaccine, we're going to give you a free donut, because they're trying to do their part. And thinking about how they can also encourage people to show that these vaccines are good. But to your point, it's also important to think about the historical pieces of this, where when you may have a corporation saying, we want you to do this, knowing the history, especially against Black folks, of experimentation, it does look like bribery. It does look like, hey, why are you so focused on this? Because of our historical trauma. But I do think that is because companies like Krispy Kreme and others are just like, this is a good thing. We want everybody to get a vaccine. You get a vaccine, you get a donut. They're just trying to do their part.
Yeah, and Nisha, to your point, there are some companies that are telling their employees, we'll give you $100 if you get the vaccine. So, I think that it has even gone beyond, and I think that there is some natural mistrust when those sorts of things happen. And I don't know the right way to do this, right? We need as many people to get as vaccinated as quickly as possible. But I agree with you that it's like naming the thing Operation Warp Speed. Well, that was a bad idea, because now that just tells everybody like, oh, this thing went faster than it was supposed to do, right? It's like your company come up and be like, hey, I'll give you $100 if you take that vaccine. It's like, no, wait. That's not the way to approach doing this. And yet at the same time, we just all have to get vaccinated as quickly as possible to be able to pull our way out of a disease that, as we know, disproportionately affects our community. So, I think your question's a great question. I don't know what the right answer is, but, it's another thing that makes you think in the back of your mind. It's like, why are they trying to give me money to do this? So I completely get it. And yes, it has become a part of this.
Or donut.
But that's partly why we're doing these conversations, right? Because, these folks, Dr. Briggs and Dr. Garner, are in the trenches every day doing the work. And so they're most informed about what's going on. And it's not even just the work that they're doing on a day-to-day, but it's also from the other levels of which they're doing their work of their research and how to look at the issue and the information they're pulling in. And even being vaccinated themselves, like they can give you a context that you're not going to find from somebody talking on TV, right? And so I appreciate the question that you asked, Anisha. I saw your secondary question, and if we can get back to it, I'll definitely ask about the lawsuit piece. But I want to move to Alexis Cartagena. I apologize if I'm saying your last name wrong. In the chat, she said, "Can you comment on your experience combating and navigating the SARS-CoV-2 pandemic at a sad time in American history that has been marred by police brutality and social injustice against Black communities in our country?" So kind of like putting it in context of what's actually going, what has happened, and what we're calling here, you know, the Freedom Summer of last summer, like how all that kind of came into play. Like, what does that look like from your experience in the work you've been doing from there?
Yeah, I guess I'll just start. Last summer was hard, right? Because, you know, not only sort of professionally am I in a moment where, look, infectious disease testing, clinical microbiology, this wasn't normally front page news, right? I'm not getting calls by the New York Times normally to talk about these sorts of issues. And so just the weight of the pandemic and the pressure of the pandemic and trying to support the healthcare system, and at the same time recognizing the inequities that were there, were enough. And then on top of that, you know, the ever present and yet laser focus in on police brutality against Black lives came to a head, right? And so we had this balance where you want to be out in the streets protesting, and at the same time, I need to be here fighting the pandemic. And at the, you know, so all of these things were coming together. And I know, you know, Dr. Briggs and I have talked about this. It was incredibly difficult to be a Black physician, a Black scientist, you know, to be professionally involved in fighting the pandemic. And then, you know, your heart is in the street, in the protest. Like, it was really, it was hard. It was really, really hard. And Alexis, I appreciate you pointing it out, because yeah, it was one of the more difficult times in my career for sure.
Yeah, and I feel the same way. It was just challenging in every single way. And I can tell you from all the various different perspectives and hats, you know, the pandemic, it was very clear by summertime who the virus was killing more of, and who was getting sick with the virus. But then we're also dealing with, again, the deaths from the hands of police and others. And, you know, there was even additional things that were going on professionally, because there was an awakening even about police brutality. And so as an emergency doc, guess who brings patients into the ER oftentimes? It's law enforcement. So there was a huge just outcry even about law enforcement in the healthcare setting and making sure that we advocate for our patients. So it was that professional piece of fighting a virus, fighting medical social injustice, and making sure that our patients had a voice, especially our Black men and our brown men. But then there's that personal piece. I'm the mother of 2 young Black boys, and knowing no matter how well I raise them, no matter how respectful I teach them to be, no matter how brilliant they are, that our current country, they will still just be looked at by the color of their skin, and knowing that we have to fight that. But yet also teach them how to protect themselves as well. It was the most hardest part of my life. And it's still hard because we're still in it. And so this year, 2020, and we've seen still a bit going into 2021, this is the awakening. This is the continuation of what so many of our ancestors fought for in the 50s and the 60s, and even before then, all the way through time. And it's now our time to lead the revolution and lead the movement.
No, that is fantastic. I have one silly question. Well, I don't think it's silly, but I'm gonna ask it anyway. So the CDC updated their zombies regulation around, you know what I'm saying? So I'm like, COVID-19, vaccine, zombies. Somebody tell me something. I just need to know, like, is there causality there? Or am I just kind of putting it together in a way that's just like, no, I just got to ask, you know?
I think the challenge is, you know, you had an organization like the CDC who has historically done things a little bit tongue in cheek, right? They put the zombie package together, but like when the CDC becomes a political voice, as it did over the last 4 years, unfortunately, suddenly things aren't funny anymore. And like, you know, the seriousness and their ability to get out information, you know, when we're not in a pandemic, again, a lot of people don't think about the CDC, but you know, the clarity of their voice, I'm just glad that we were able to return to some level of trustworthiness, some level of seriousness about what our scientists say and how they need to shape policy. And I'm glad we're moving back into that particular space, because as a scientist, you know, the last 4 years of rhetoric that pushed us away from science really was frustrating. And I'm glad that the CDC now has leaders and voices and are being listened to shape policy, because it's going to be so important to save lives.
I appreciate you. I teed it up and you gave me exactly what I needed, Dr. Garner. I appreciate you. There's actually 2 more questions. One from me, and then also from Mr. Fred Atkinson. I'm gonna let him go first. Fred, if you would like to unmute yourself so you can go ahead and ask your question about resilience. Fred, you still there?
I think he's still.
You can go ahead. You gotta
Unmuted.
unmute yourself. There you go.
Yeah. Okay.
There you
Thank you. Thank you so much, everybody on the call, and most certainly the 2 doctors. I have a sort of a nebulous but important question. From the background information that we have gathered about African Americans, Latinx, and other minorities through their trauma over the years, and the Native Americans, is there anything that provides a bulwark of resistance against these unknown elements, such as COVID-19 and perhaps variants thereof? Just as we've been, predisposed to, diabetic conditions and other diseases, is there anything in broadly speaking, that we can take to the table and utilize in some fashion against such infections going forth?
Thank you for the question. And so just to make sure that I'm clear, you're saying, is there something that we can do in order to prevent future situations such as, let's say, COVID virus impacting communities of color? Is that more of the question?
That's not it. It's in our background, in our DNA, RNA. Is there something through the years and the resistance that we have had as peoples that will help us in COVID-19 and perhaps other diseases that might be forthcoming?
Got it. Well, a couple of different things, and Dr. Garner, I'll throw this out to you as well. We intergenerational, we continue to get stronger as a people because we build up various different immunities over time. However, even according from the Human Genome Project, our DNA is 99.9% the same. And a lot of the various different impacts that certain diseases, certain viruses, and other medical conditions have had that have been seem to be more racially disproportionate is not necessarily from DNA per se, but is from all of the structural factors and oftentimes racism and other pieces that cause one group to be more impacted than the other. COVID-19 is a perfect example. The reason why we saw the high rates of viral infections and hospitalizations and deaths was really due, and especially within low-income communities of color, we could see it due to higher rates of exposure, higher density of housing, the types of occupations, especially those that lived in more of our lower income communities had. And so that exposure on top of chronic medical conditions due to numerous reasons is what led to the higher rates of infection, hospitalizations, and deaths. So is there something in our DNA per se that can cause or build up to resilience? I would say that all of us, regardless of our background, we have the same type of DNA, but what will build up our resilience is taking into account these social structural factors that lead to the long history of racial minorities being more afflicted by various different diseases than others. So that would be one thing. I hope that answers your question to a certain extent. We got to start looking at the systems and the approaches and the clinical practices that have caused us to have disproportionate and worse health outcomes. And because it's not rooted in our true genetic material, it's rooted outside of us, which is what's causing this.
Mm, mm. And I think to that end, that actually brings me to the last question of today. And I want to say thank you very much for your time. And I'll wrap up everything, put a bow on it after we get done with this question. But it really comes down to access, right? I was looking at NewsHour. They did a segment about the folks who want to take the vaccine and what the race look like. And it's actually there's more GOP and Trump supporters who don't want to take a vaccine than there are Black folks. But there was a Black doctor inside that segment that said, I don't want to get messed up in this conversation around people who want to take it, who don't want to take it, because really the biggest problem of the reason why Black folks and people who live in communities of color in most impacted areas is access, right? Access is really the biggest problem. Access to the vaccine, access into the healthcare system at large. So from an equity standpoint, from your point of view, what are some of the things that we can do more of? And when I say we, I'm talking about the work that you all do from UCLA Medical and your peers across the spectrum, and then also organizations like us who focus on equity and do work around health equity. Like, what are some of the things that we can be doing more to be able to bridge the gap, or actually really the chasm that exists for access for Black people and those in the communities of color in impacted spaces?
Yeah, so I think I'll briefly start and then give this over to Dr. Briggs, who has spent her career thinking about that particular question. You know, Derek, to me, it's about shining a light, right? I think that it still is not recognized that there are healthcare inequities due to racism, right? And like, there's an entire thing going on in the medical community right now around this conversation of race and racism and its impact. And there are still people who just don't see it as being real. So to me, this is about, if you're an organization, if you are UCLA, you have to shine as bright a spotlight as you can on these healthcare inequities, on these disparities, and exactly how they work, and define how they work to be able to make solutions. So to me, it's about bringing them to the table and actually presenting them as what they are, not dancing around them, not saying these are because of structural racism. These are because of institutional racism, and we have to address them directly.
And I 100% agree, because again, it has been proven over and over again, as I just mentioned, it has nothing to do with genetic material. We are all the same, but it's the racism and it's the structures that prevent access, direct care, also all of those other social factors that are rooted in historical racism and oppression that continue to contribute to health. But when it comes to the COVID-19 vaccines, and especially for those of us here in Los Angeles, we know that around April 15th or 16th, we're supposed to be opening it up for everyone to get the vaccine. And I think this is our time that we start bonding together the health clinics and systems directly along with our community-based organizations, just like Social Justice Learning Institute. And we identify the best ways to get those shots into people's arms. Oftentimes it's a health system and we're totally separate and we're thinking, oh goodness, how do we make sure we distribute this equitably? Instead of partnering with community, instead of partnering with our community-based orgs and saying, what do you all think is the best way? Do we need to set it up in this community? Do we need to set it up at these hours? We'll bring the shots, you bring the people, and we'll go forward that way. So this is going to be our time to really join together and make sure we're meeting the needs of the Black community, of the Latinx community, of all of our communities of color who have not had as much access, and we're not just staying and sticking to those methods that we've done in the past.
Well, that is amazing. I think that's a perfect way to bring this to a close. I want to say thank you again for taking the time out of what I know are your very busy schedules to doing the work that you're doing on a day-to-day basis. I want to give you flowers because you're doing amazing work, right? On behalf of folks, you know, the piece about the ways that you're working inside to transform systems, as well as working to engage those of us who really want to be supportive in that. Like we're here to really bridge that gap, and that's what these conversations are for. I want to wrap this up by saying thank you to you all for taking the time out on your Saturday in the afternoon. You didn't have to be here, but you decided to take some time out to learn a few things. Hopefully the conversation was fruitful for you. You know, these community conversations, this is the first one, but we're going to be doing this every month into the summertime as we begin to transition back to this new normal. And some of the things we're going to take from what we used to do, but more of the things that we've learned along the way that we're going to be doing in a totally different way moving forward. We want to have conversations about that and bring us together so that we're all moving in the same trajectory. These conversations are also brought to you in support of the work that over 130 CBOs are doing to work and to provide and improve access around information. It is the California Community Outreach Project, supported by the California Community Foundation. So there's a lot of great work that's happening. We're not the only ones trying to do this work. There's so many of us that are doing it. And so thank you very much. Have a great evening. And tell your friends and family to come join us. When you see the flyer pop up on your Instagram or your Facebook or in your email or on your text message, because we're going to be sending out text messages too, or we may call you, tell everybody to come on and join the family conversation that we're having today. Dr. Garner, Dr. Briggs, I hope you have a fantastic rest of your weekend, and we'll talk soon. Until the next time, everybody, have a good one.
Thank you.